The next important topic that we are going to talk is about inflammatory bowel disease, on which a lot of questions come. It's a important area even in surgery. In medicine, we are not going to once more discuss medical gastroenterology because a lot of things which are covered in surgery are taken care. Now, let's make the best out of what we can remember and reproduce in exam about inflammatory bowel disease. You know, there are two forms of inflammatory bowel disease: Crohn's and ulcerative colitis. Inflammatory bowel disease is another disgusting situation in a patient's life. I remember one of the excellent chefs is one of my patients in one of the best hotels. He cooks so nice. At the age of 30, he got succumbed to ulcerative colitis, and luckily the remission was very good, and he is able to continue as a star chef even today. So, he being our patient, whenever I dine in the Taj Hotel, he offers an extra post-dinner soup, post-dinner ice cream free. So there are few privileges of being a clinician, right? So suppose if you are a physician treating prisoners, you will have some more privileges later on after they come out of the jail. So let's talk about Crohn's disease. Yeah. So we used to have a prison posting in Warangal. So go and see the prisoners. While doing MBBS, some of the prisoners, they used to be very articulate, nice speaking guys. We used to think, did they really do 20 serial murders? So that's the thing. Chronic inflammatory condition is Crohn's. Crohn's can involve any part of GIT. But generally it involves the distal ileocecal area, small intestine, colon. They are involved, but it can involve any part. Second to third decades of life is the time where Crohn's is typically seen. Crohn's can ultimately lead to carcinoma of either the small intestine or the colon, is what need to be basically remembered. Now, this is a typical example of a gut which is involved in Crohn's. What do you understand by this? This is basically a portion of the terminal ileum. A lot of times an question is asked, terminal ileum, is it involved in Crohn's or not? It is involved in Crohn's. In fact, Crohn's can involve any part of the GIT, is what you need to basically remember. And particularly Crohn's involves terminal ileum. Terminal ileitis is a very important location. So there is an endoscopic appearance in the colonoscopy which is demonstrating in a Crohn's the presence of the mucosal erythema, which is a classical feature. Now, what is this important appearance in the Crohn's is basically called as, doctor? Typically, it is involving the small intestine and irregular nodular appearances with hyperemia and superficial ulceration is what you are able to see in the small intestine in a patient of Crohn's, is what need to be remembered. Now, doctor, $1 million question of the examiner. Compared to Crohn's, is the tendency towards malignancies more or less for ulcerative colitis? Ulcerative colitis more likely to become malignant compared to that of the Crohn's, is what need to be remembered. It is a transmural inflammation, which is a classical feature where all layers, mucosa, submucosa, serosa, everything become involved. There is a thickening of the involved segment so that there is a narrowing of the lumen. There is a linear ulceration of the mucosa which can happen in case of the Crohn's. And all that submucosal edema lead to the elevation of that surviving mucosa, and that lead to typically that cobblestone appearance which you see in the case of the Crohn's is what need to be remembered. Then Crohn's can have, and only Crohn's can have, skip lesions, where there will be normal areas of mucosa intervening between diseased mucosal areas. Other way to know is Crohn's can only go any part of the GIT. Unless it skips, how will it go? So skip lesions and Crohn's is what need to be remembered. In Crohn's you have granulomas in some of the areas and submucosal fibrosis leading to stenosis, fistulae, etc. are the features of the Crohn's is what need to be remembered. Now let us look at a histopathological appearance. Transmural inflammation, where the inflammatory cells are extending all the way from mucosa through submucosa and muscularis mucosa and infiltrates into the serosa. Transmural is what you need to remember about the Crohn's. Then, what is this special feature you are seeing in the Crohn's? Granulomatous inflammation of the Crohn's with epithelioid cells, giant cells, is the feature which you are able to see in the case of the giant cells. You are able to see the giant cell? So granulomas, giant cells, these are all the features of the Crohn's. Then, what is this important feature? Typically, you can see that the inflammation here is widely spread across all the layers in the histopathology, is a feature, transmural nature of the Crohn's. Now, what are the clinical manifestations of the Crohn's, doctor? How does it clinically ultimately will present? Abdominal pain, diarrhea, malabsorption, fever, and due to that fibrous stricture it lead to intestinal obstruction, and fistulas can form. And after all, the GIT is in a very strategic position in relation to a lot of pelvic organs. Fistula between colon and bladder, colon and vagina, colon and the skin, intestine and the skin. So all these fistulae are typical of Crohn's. Then both the Crohn's and ulcerative colitis will present with some extra intestinal manifestations, doctor. Polyarthritis, uveitis, episcleritis, sclerosing cholangitis. These are all the important extra-intestinal manifestations. Similarly, sacroiliitis, erythema nodosum and pyoderma gangrenosum are the classical extra-articular dermatological manifestations of the inflammatory bowel disease. We will discuss sclerosing cholangitis separately. So what is sclerosing cholangitis? In this there is a chronic fibrosing inflammatory process of the biliary tree. Ultimately it presents in the form of portal hypertension, can be the complicating feature. Now coming to the ulcerative colitis, what are the main issues that you need to basically remember, doctor? The mucosal inflammation and ulceration, which you see in ulcerative colitis, is mainly limited to the large intestine, hence called colitis. Rectum, proctitis is there, no? Rectum is a part of the colorectal colorectal tract. Rectum is always affected, just the way ileocecal area is generally affected in Crohn's. Rectum is always affected, but even the entire colon can also be involved, is what you have to basically remember. And in this it is only mucosa, submucosa, not muscularis and serosa. And crypt abscesses and ulcerative colitis are the classical features. What is meant by abscess? Since there is infiltration of neutrophils into the crypts of the Leiberkern in the GIT histology, we call it as crypt abscess in the case of the ulcerative colitis. It is ulcerative, That's the reason mucosa looks red and granular in appearance. And how will be the ulcerative part of the ulcerative colitis? Ulceration can be minimal or extensive. If it is very extensive, ultimately what is left over in the colonic mucosa is just a few surviving islands of mucosa. Everything dead, necrosed, with only few islands left over. That is what it will typically happen. So, those mucosal islands which are still surviving in the midst of that ocean of necrosis in ulcerative colitis lead to what are called as pseudopolyps is what need to be remembered. And how do they present? They present with chronic diarrhea, stool mixed with blood and mucus. In fact, the most frequent clinical manifestation, if I ask you, is it abdominal pain, is it what? Then what is your answer? It is basically the bleeding is the most frequent complication, presenting feature. Then what are the complications? Ulcerative colitis alone lead to toxic megacolon. Once more in general surgery we are going to read. If there is a toxic megacolon in a patient, what are the guidelines to manage a patient of toxic megacolon? You need to be very sure. In fact, toxic megacolon is a medical emergency. Once more, what is the size criteria for calling it as toxic megacolon? Everything anyway we need to discuss in surgery, no? Let us leave something for honeymoon. So that is what, there is no point in quarreling everything before marriage only. So some things, some places we need to leave for discussing and debating. Perforation of the colon can occur, which can lead to become a surgical emergency. Carcinoma of colon is more common in ulcerative compared to that of the Crohn's is what need to be remembered. Now doctor, let us see few features of ulcerative colitis. What do you appreciate in this, doctor? Basically, in ulcerative colitis, in the sigmoid colon and ascending colon, there is a continuous erosion with few islands left over called pseudopolyps. In case of without any skip areas, a inflamed colon is what you are able to see. Then pseudopolyps are the raised red areas of islands of the surviving mucosa is what you are able to see. Then another example of an extensive ulcerative colitis in a given patient is what you are able to appreciate. Then and another thing is that mucosal inflammation and erythema and granularity are the hallmarks of inflammatory bowel disease. Then there is a typical endoscopic appearance of a patient with ulcerative colitis, and only when ulcerative colitis is very severe, if you are able to see pseudopolyps, means that the leftover hope of few surviving islands of mucosa. Hence, presence of pseudopolyps is a marker of severity, that it is very severe case of ulcerative colitis. Then what kind of inflammation do you find, doctor? Only confined to mucosa. The inflammatory infiltrate is there, no, this. It is not through and through spread the entire wall. It is not like that in ulcerative colitis. It is only limited to the mucosal area, not transmural. Then you can once more see in a higher magnification the same thing. All the inflammatory infiltrate is strictly localized only to the mucosal area, is a feature of ulcerative colitis. Then this is once more an example of crypt abscesses in which the inside the glandular lumen of crypts of Libercan, you are having inflammatory infiltrates which lead to the typical appearance grossly as the crypt abscesses is what need to be remembered. So this is once more inside the lumen of the glandular lumen, you are able to find the inflammatory infiltrate, which is basically called the crypt abscesses, which is very typical feature with the ulcerative colitis. Once more, what do you see here? Over a period of time, there will be, you can see this is the normal colonic mucosa, and this is the dysplastic. Are able to see that hyperchromatic nuclei, doctor? So dysplastic changes are appearing in the mucosa, which is a precursor for a malignant transformation, which is more commonly seen with ulcerative colitis, is what need to be remembered. So what is the summary, doctor? The anthem of inflammatory bowel disease. We need to sing before we close the topic. Differences between the two. Favorite area for examiner. So only colon is ulcerative colitis. Then mucosa and submucosa only is ulcerative colitis. And cryptabscess pseudopolyps in ulcerative colitis. But non-caseating granulomas, fibrosis, thickening of intestinal wall, formation of fistulae, formation of stenotic areas, cobblestone appearance, skip lesions, they're all the features we talk about Crohn's. And secondary malignancy is much more greater in case of ulcerative colitis. Take it as my word, doctor. If you take the previous exams, any exam you take globally, inflammatory bowel disease is an invariable concept without any secondary thought. You must be thorough. Where is cobblestone, where is pseudopolyp, where is fistulae, which is transmural, where are skip lesions, everything you need to have in tips, doctor. So I hope you are now confident to take up this topic. Thank you.